ado, let's go on to today's speaker. So I want to welcome Terry Vanden from the Department of Emergency Medicine. Terry is a professor and head of emergency medicine, and Terry has been a leader here in a number of different respects, certainly in the global health field. In the global health field, he leads the India Heart Rescue Project, which leverages off the Illinois Heart Rescue Project. He's going to talk about today, and we're really proud of that project and that collaboration on so many different levels, as a model of partnership, as a model of leveraging science here, science and practice here internationally. It's a really fantastic project, so I look forward to hearing about that. Of course, the Department of Emergency Medicine is also a leader in training. They have an International Emergency Medicine and Global Health Fellowship, which is really outstanding. Stacy Chamberlain and Janet Lynn are also very involved in that. I guess the other thing I wanted to highlight that I know about Terry, and I know about him from his work, and I know about it personally from interacting with him over the last several weeks, that it's a vision of emergency medicine that is really socially engaged and socially responsible. It's concerned with not just who walks in the door, but also what goes on outside in the community, in people's lives, and how can you leverage the emergency contact into, say, primary prevention types issues, addressing NCDs. So it's a good model for thinking about low resource communities and global health. There are many, many accomplishments, grants and papers and all that. I'm not going to read any of that stuff to you. Let's give a round of applause to Terry.
Hey, so I want to thank everyone for the kind invitation to be here today. I think this is a magnificent idea to bring together so many people from different disciplines. It's one of the things that attracted me to the University of Illinois. I've been here for 7 years now. It's gone really fast. So I was at the University of Chicago for 15. But I came here because I saw a commitment to the community to bringing many different disciplines together to solve big problems. And you guys haven't disappointed me yet. So I want to tell you about a project today that we've been involved in with the help of many that are here. But it reflects a commitment to social emergency medicine, as something our department is calling it now, and health for all of us. That things that we do here, we want to bring to India. There are things that we're learning in India that we think we can bring back here. And I think that's a vision for global health that becomes really exciting. So let's talk a little bit about reducing global heart disease burden, and particularly how we are approaching it in India. Just want to disclose where some of my support comes from in terms of the project support and funding currently. So this is a Medtronic philanthropy grant. It's a foundation grant. They have invested worldwide in rheumatic heart disease. They have it's not just an emergency care perspective, so there's the heart rescue programs that are part of the United States and now have moved, based on some of the work that's been done in the United States, into India and China. There's also a project in Brazil that's starting up. And then they're also very interested through HealthRise in the continuum of care. So if we take care of a heart attack patient, we don't just stop there, but we think about prevention and how do we prevent the next heart attack from happening. So that is a perspective that we have brought into this program. And if folks have questions along the way, we have certainly room at the end for questions, but I can also take questions through the presentation. Okay, so from a perspective of cardiovascular care, and this is work that was published recently by Mark Hoffman, who was, I think, invited to one of the global health seminars last year and gave part of a talk. If you just look at the years of life lost because of population, because of the incidents of disease, there's a couple notable things that are happening. So India and China particularly stand out. India stands out even more because of the ischemic heart disease burden that you see in terms of years of life lost. If you look at the age of patients when they have a heart attack, it's much younger. There are many patients that are in their 40s that have a heart attack for the first time. China's notable because of the increasing incidence, particularly of stroke. And of course, because of the population, the years of life lost is enormous. There are people that are calling this one of the largest worldwide epidemics. From a perspective of a cardiac arrest investigator, someone who cares about cardiac arrest, half of the world's heart attacks and cardiac arrests in the next 10 years are going to happen in India. And so that's a compelling reason for when I met Tim Erickson and Prab and Ria and learned about the Center for Global Health. It's a hard thing to ignore and not to go over there and say, how do we bring some of the things that we've learned in Illinois? We've almost doubled cardiac arrest survival in 3 years in the state of Illinois because of the Illinois Heart Rescue Program. And I'm not going to go through much of that today because there's plenty to talk about related to India. But that Illinois Heart Rescue started with just a few hospitals. It was a coalition that said we're going to improve outcome from a leading cause of death in this state, cardiac arrest. And we built a coalition that had to engage the community for bystander CPR, for paramedics to actually think about how they deal with cardiac arrest in the field, and then the hospital. And a fundamental principle was sharing data. We collect data on every case of cardiac arrest that happens in more than half of Illinois at this point, and we learn from that information. And as a result of that quality improvement process and engagement, we've doubled survival in just 3 years in our state. So that is something that we wanted to bring, and we were invited by Medtronic to say, hey, whatever you're doing in Illinois, do you think you could maybe bring this over to India? Okay? And we have a big problem on our hands, yes? So one of the things, this is work that the Institute of Health Metrics and Evaluation has put together as a ranking of disease-adjusted life years. And you can also see that things have changed in India. And when you just look at what's happened in the last couple decades, that the global burden of disease by cause has changed significantly. The thinking is that 80% of this disability and premature loss of life could actually be prevented if we had better systems of care and risk modification in India. Okay, so Dr. Prabhakar invited our group to visit India at one point, and we actually visited a few sites. But one partner that really stood out was MS Ramia. And when we looked at what the possibilities were, Illinois at that point was part of the Illinois Heart Rescue Program. It's a partnership with several other states to improve outcome from cardiac arrest. MS Ramia is a medical school that partners with many other schools in terms of discipline. So like us, they have several health sciences colleges. So they think in a very interdisciplinary way. They have an engineering school. They're in Bangalore, which is kind of one of the Silicon Valleys of India. They have a significant number of STEMI cardiac arrests. So we started discussions of how could we bring what we've learned in Illinois to Bangalore. Bangalore is a population of about 12 million people. For those of you in the audience who are from Bangalore, I've already met some, so if I say anything wrong about Bangalore, also just let me know. But Bangalore is a much bigger city than Chicago. Okay, so a few things that I wanted to, as I've talked through with Steve, one of the things that we actually have been following as one roadmap was a community resiliency model. Getting to know the community in Bangalore and India was a really critical part of this story, forming a coalition based on that community engagement. And we're actually kicking off officially our implementation We actually started data collection just as of December 1st, but we're going to really start some other quality improvement practices next month. So it's a real kickoff. There are fellows that we'll be bringing. We have, I think, one of our largest groups, right, Rhea, in terms of bringing people out, so we're trying to figure out how to get everybody out there. We have weekly conference calls. We visit India on the ground twice a year. And so there's been a lot of engagement. We really believe in train the trainer. And so when we leave, we really make sure that we've imparted some things that we're hoping will continue when we leave. Okay, so this is some work that was done by the Institute of Health Metrics and Evaluation. So they are a partner in this grant, as is the Research Triangle Institute from Duke. They're an implementation partner. IHME is an evaluation partner. So they've done some landscape analysis already as part of understanding what is the community that we're going into here. Okay, so they do household surveys. They've started some health facility assessments and EMS agency assessments and stakeholder interviews. So there are 80 wards in Bangalore. They've done some assessments in 40 intervention wards and then 40 non-intervention. So we're focusing on an area that's about 500,000 people. But they interviewed 2,400 individuals. And you can see that it's a relatively younger population in terms of the folks that they looked at. There are a fair number of college educated, but there's also a fair number of people that only have a high school education or less. And this is the demographic by age and sex that you can see. So again, it's a relatively young population. And unfortunately, heart attacks are seen in a much younger population as well when you compare it to other places in the world. This is the education level, and again you can see that around MSR there are certainly areas that there are, just like in Chicago, there's a pretty striking disparity in terms of differences in education and income across the area around MS Ramia. And then you can see the income by rupees, and 1,000 rupees, Prab is about $30. Yep. About, so $1,000 is 30 rupees. So it's not there's a from a socioeconomic level, there's a wide disparity. There are a number of slums in Bangalore that are close to MS Ramia, and those are areas that we need to think about how do we message in those areas. The population can be more transient compared to others. And then the insured versus uninsured rate makes a huge difference in terms of how people think about accessing care. And so you can see that in this area there's a lot of uninsured patients. So one of the things that we have to think about is, as the government policies change, can we get people onto insurance? There are aspects of this program that, as we message to the community, we want to make sure that people know that it's provided free, so we're not going to charge them a whole bunch of money for an ambulance transport. And so those are all things that you have to start thinking about as you get to know the community that we're trying to serve. And then this is again just by demographics. You can see who has insurance, and there are different types of insurance. I think that the government of India, compared to other countries, probably spends less of its GDP than almost any other country kind of in its tier right now for medical care. And I know there's a lot of discussions about how to improve insurance in India. But obviously, if you don't know what the cost of care is going to be and you don't have insurance, that's a real barrier to getting access to care. So that's something that, as we're talking to the population, we need to address. All right, so what does heart attack care look like in India? So one of the larger studies that's been done was in Lancet in 2008. Dennis Xavier was one of the lead authors on this. He's one of our collaborators on this project. He is on our advisory group. We will be meeting with him in February when we're out there. So it's just a broad overview. This is from 20-some thousand patients that were looked at in India that had ST segment elevation myocardial infarction. So that's a STEMI. It's the worst type of heart attack. Can damage the heart very quickly. You need to reperfuse that within, ideally 90 minutes to save as much of the heart as possible. If you don't, the patient can have a cardiac arrest. They can end up with congestive heart failure and be debilitated for the rest of their life, not be able to do activities of daily living. It's a big deal. So in India, when you look at the patients that were in this, and this was through multiple cities in India, including Bangalore, 60% of patients had STEMIs compared to what we call NSTEMIs, and so it's the more severe type of heart attack. In the United States and other places, our ratio is a little different. We have more NSTEMIs than we do STEMIs. So they have the worst type of heart attack is the predominant type of heart attack in India. Furthermore, patients are younger. They tend to come from a lower socioeconomic status when compared with NSTEMI patients. There are also differences, by the way, in gender. And women don't get treated quite the same way as men. The mortality rate is higher. The median time from the onset of symptoms was 300 minutes, and that's more than double what's reported in developed countries. So people wait way too long. And remember that part where, 90 minutes is where, that's where the heart starts to die. And so there's some significant delays in care. Even when people came in, only 60% received thrombolytic therapy and only 8% underwent percutaneous coronary intervention, which is, you go to the cath lab, they put a catheter in an artery, and they go up and open up the blockage. And that is a much higher number in developed countries. And so, again, there's a lot of room for improvement. And then the patients that were seen were very high risk. 30% of those patients had diabetes, almost 40% had hypertension, and over 40% were smokers. So big opportunity for secondary prevention. And if you're going to discharge these patients, it certainly would be nice if it wasn't just, boy, you're really lucky, we saved your life, and that's it, good luck. I think we want to do more than that and say, hey, let's talk about some of these risk factors so this doesn't happen again. And some of our fellows that have been out already in India have commented that one of them saw the same person again, repeat heart attack. And so those are things we really want to avoid. So some of the barriers that have been identified so there's been this needs assessment. We've had multiple meetings with stakeholders in Bangalore. So there's this prevalence of at-risk individuals that we've talked about. There's a delayed recognition of symptoms. There's little CPR knowledge. Actually, when you ask, 90% of interviewees from lower middle socioeconomic status never heard of CPR. That's a problem because people that have STEMI, in the first few hours of onset, many of them, 10%, 15%, maybe even more, could have a cardiac arrest. And so within that window of time, that's an opportunity that if somebody knew how to do CPR, they could save that person. So that's part of the system of care that we've put together in India. There's this great fear of illness and related costs because a lot of people don't have insurance. And then there's this issue of detours and the initial STEMI care to primary clinics. And there's not a concept. So in Chicago, there are STEMI hospitals. We are a STEMI hospital. Chicago Fire Department brings patients that have a diagnosis of this ST segment elevation myocardial infarction to STEMI hospitals. There's no such type of system in India. So kind of depending on what your favorite hospital might be or where your primary care doctor tells you to go, you may go there, but they may not be a hospital that has a cardiac cath lab or knows how to kind of take care of a STEMI. And so some of the focus groups that have been done by colleagues out there, you can read this quotation at the bottom that when you talk to people who have had a STEMI and like, how did you get here? And patients oftentimes trust their primary care provider and talk to them first. And then there are delays from that. Sometimes the primary care provider says, hey, just take an antacid and I'll see you in the morning. Or they get referred to the wrong place. So there are delays in the system. So there's a community awareness thing. There's also a primary care provider awareness of this being a challenge. So there's also this matter of cardiac arrest, and this is what happens when you go into a community and you really listen, because Illinois Heart Rescue is about cardiac arrest. We're not focused as much about STEMI and heart attack. When we went to India, the Medtronic initiative was actually thinking about just focusing on cardiac arrest, but when you talk to the stakeholders, they said, well, everybody's dead. Like, there's no, it's like 0% survival. So what's your goal? 1%, 2%? We're going to have a lot of dead people being brought in, and people aren't going to be very excited about moving that forward. And why not start with people with chest pain? Because we think that for every 10 STEMI patients, there's probably 20 people that had a STEMI and died at home. And that's literally what they told us. And so that put together some ideas that said maybe we need to really, let's put together a chest pain pathway here, that if you're having chest pain, you might be having a heart attack, call this number. We're ready to do that, and we're prepared. And we're prepared to take care of a cardiac arrest if it happens along the way. So those are the ideas that we started to put together for India. So around that, we started to form a coalition. One of the things that we realized is that CPR training was an important part of building this network, and that was based on the needs assessment that IHME put together. So a lot of people may have known about CPR, but they did not know where to receive training. They didn't have the time. Particularly concerning with people that had, at a lower socioeconomic level, had never heard of CPR. There were a fair number of people that knew what an automatic external defibrillator does, and there was a willingness to learn that. So we think that in the community that, hosting Resuscitation Academy, we call them events, and we're doing that in February, raises awareness in the community. They feel empowered to do something. Within the context of CPR training, we're talking also about heart attack recognition, heart attack action planning, and we're trying to mobilize partners in the community like Civil Defense. It's a very large volunteer network, and then stakeholders in our hospital system to use CPR training as sort of an anchor, but then build on that and talk about, well, what leads to a cardiac arrest? It's delays in getting care for a heart attack, and how do you get help earlier? You can call this number. It's free. You don't have to pay for the ambulance. We're going to make sure that you're taken care of well. Okay, so it's just a couple maps, and so this is our coalition in Bangalore. It's a partnership of 2 what are called hub hospitals and 5 spoke hospitals. And these are hospitals that are come together and said, you know what, we want to combine our resources in terms of personnel. We all have ambulances. 2 out of the 7 of us have a cardiac cath lab. And we want to put a coalition together that can respond to calls with chest pain, possible heart attack. Now, India has a 911 system. It's called 108. It was developed for women who were having a baby and trauma. They do not have the capacity yet to respond to every call. If you just look at the number of advanced ambulances in Chicago, I think we have like 10 times more ambulances than Bangalore does, and Bangalore has like 10 times more people. So they don't have the capacity, okay? So part of this coalition is to say, let's put more ambulances into this 500,000 group of people, this community. Let's coordinate the care here. And if there's a call, we're going to have a nurse paramedic go out on a scooter, and so that'll help get through traffic, and we're going to have a video at the end that'll show you a little bit about what traffic looks like in India. And you'll know why we want to do it on a scooter. But they're going to have an EKG machine that can actually diagnose STEMI in the field, and that can prioritize where ambulances go. And then ambulances will bring that patient to a hub hospital that can care for that heart attack patient. Okay, so they can go to the cardiac cath lab. If there's going to be a delay in transport, they can get thrombolytics at that spoke hospital and then get sent to more definitive care. So, and we looked at the number of cases that we thought we might have, and the idea of this is to look at, well, how much does this cost to build a coalition like this? And if we measure what the outcome is, and we have this data portal that you can enter data, just like we do for Illinois Heart Rescue. Every hospital can enter data about the cardiac arrest case they saw. We just went live with a data portal that every STEMI patient, every chest pain patient actually comes in a hospital. They actually put data into looks like a little iPad, and it goes up into a cloud. And then it can put together a data report at the end of the time the patient's been in the hospital, and you can look at all of the key metrics of care that had happened with that patient. It's actually more sophisticated than what we have in the United States because you can enter it in the field as a paramedic. I can hand it off to Dr. Janet Lynn here in the front, and when I come in as a paramedic, and she has her own iPad, and there's a unique identifier, and she continues the care of that patient. She handed it off to Dr. Chamberlain, the cardiologist, who can enter the additional data, and at the end of it you have a report. And you can look at, did we reperfuse this patient in time? Did we get to the patient's house in time? And we can look at areas that we need to improve. So does that make sense to everybody in terms of what we're trying to do with this coalition? Any questions so far? Okay. So, okay. I didn't know if this microphone was carrying, so, all right. So some other barriers to address by this coalition. So the public perception of the pre-hospital system for STEMI response. Most people in India do not use 108. Okay, like 95% of people that have an emergency are going to get to the hospital in another way, and there's a lot of reasons for that. There's questions of timeliness. There are questions of the ambulance may not bring you to the hospital you want to go to unless you pay them extra money. Then they might bring you to the hospital that you want to go to. Those things happen. There's questions of the quality of care that they're going to get, that the training of the person in the ambulance is not standardized. So there's a perception problem. We talked a bit about the apps and delays of best practice STEMI care for cardiac care. And, so we need to look at what are these time intervals that are so critical. This is time-sensitive care. And the only way that we think we're going to do this is we need to have a good data infrastructure that actually measures these things. Quality improvement is something we're very used to in the United States. It's been a big factor in why we have improved STEMI care in the United States. But it takes a mindset, it takes a culture. And when you get into discussions of data, there are times when it's more important for the data to look right and look good rather than be completely accurate. And it's really critical that you share that perspective that, look, we're looking for the best data that truly reflects reality so we can improve care for the patient. So those are things that we're going to be talking about this year. There's also the issue of training. There's only about 10,000 emergency medicine technicians that have been trained in the country. It's probably double now, but as a perspective, we have 240,000 in the United States. So training is a big issue. MS Ramia is a training, it's recognized as one of the best health sciences schools in many areas in the nation, so they know how to educate which is good. It's a valuable partner. They're also one of the first emergency medicine training programs in India. And so they really, they're a good partner to have, because we're hoping that if this model is successful, it's something that would be spread through other emergency medicine training programs that create a leadership there. So what we're thinking is that at this point, there's no such thing as a paramedic, but there's a community nurse and a health responder that would come from one of the spoke hospitals on a scooter. They would diagnose STEMI in the field, and this is a type of monitor that they would use handheld. There's a continuous ECG thing that can be fed into a cloud. You can diagnose remotely by a cardiologist. Based on this, you can prioritize your ambulance transport, and if it's a STEMI, you go to a hub hospital. If it's not a STEMI, or it looks like a stable patient that requires some further care, could go to a spoke hospital. And then there are patients that come into the spoke that would need to be referred to the hub. But these are things that, with a portable data entry system like this, we can measure these time intervals in terms of how long it takes us to get to the side of the patient, the transport times, and then most people yet in the first year are going to be just walking into these hospitals, yet are driving without calling an emergency number. We want to make sure that if somebody arrives, that we're reperfusing these patients in a timely way. And this is just a schematic of the care pathway, and so central to this is an ongoing quality improvement process that engages multiple stakeholders. There is a pathway in terms of our hospitals that we're working with to make sure that we're starting here, to make sure that any patient that comes in with a STEMI, we're actually measuring outcomes. We're sharing outcomes in monthly data reports. And as personnel here get better at doing this, some of these same personnel are going to be out by the end of this year in ambulances and motor scooters, so that there's a pre-hospital pathway that has been set up. And the final component is community engagement and identifying at-risk individuals that are already in the hospitals that we're seeing as patients, and letting them know about their risk. And we're designing ways to engage those at-risk individuals, to tell them about heart attack action planning, about bystander CPR. So I can share these slides with folks too if they're interested in looking at this some more. So, so there's a whole training and performance outcome. Marcia Edison is one of our training experts that's helping us with training folks, and so this is engaging nurses and physicians in the hub and spoke system. We're talking a lot about protocols and algorithms, and what you think may be a very simple thing for us is not so simple when you get into, well, what if somebody got their EKG and say, okay, if I'm fine, I'm refusing care now. The things that we're very used to, we have a pathway, a protocol for that. There aren't all those pathways and protocol books, and so we're trying to develop that in India right now. And since there is no paramedic that is recognized yet in terms of what is a paramedic, what should they be able to do, we're hoping to help define that. And what is the training of a paramedic in India in 10 years from now? And then finally, we're partnering with the community, and one of the things that we have a program in Illinois Heart Rescue called Champions that we're one of the ways that, so we have tripled bystander CPR rates in some of our worst neighborhoods in Illinois, and which is amazing because it says that we can actually change behavior in communities if we have successful engagement. And so bystander CPR is so if somebody collapses on the street, when you walk outside today, are you ready to call 911 and to do bystander CPR? About 50% of the time in most communities that actually happens pretty nicely. We have areas in Chicago where that happens almost 0% of the time. Okay, and there's many people that are collapsing, but nothing happens. There are delays in care. We look at those neighborhoods; those are hotspot communities, and we look at how do we engage this community effectively. One of the strategies we've used is high school students, and we give them homework assignments to go in and train their family. They have to get it signed off on, send a Instagram or Snapchat picture, make sure that they're really doing it, and but they love it. They're telling their parents what to do for the first time, and this is one type of program that I think has been very successful. I think Daisy is out here somewhere. Do you want to raise your hand? So she's been training I don't know how many people in some of our hotspot communities, but we've tripled CPR rates in some of our highest risk neighborhoods in a way that has resulted in successful resuscitation, patients getting to the hospital and going back home and back to work. So we're starting that type of program with Prob's help and others with 10 schools that are around MS Hermia. And again, we're talking about cardiovascular risk. What is it? We're putting different modules around nutrition and health, heart attack action planning. And again, as a homework assignment, we're hoping that they will bring it back to their family members, and as a homework assignment, bring them into maybe some training things that we do in the community, educational things at times. So we're actually kicking this thing off now. We've spent a lot of time getting to know the community, forming a coalition, and we're actually starting data collection and started in December. We're going to rough in our data infrastructure, and then we're going to be collecting baseline data in the next few months, and then we're going to be starting our pre-hospital system of care. And so this is the continuum of care. If you just look at what we're doing, we're augmenting the EMS capacity in terms of the ambulance, number of ambulances and people that are responding. We're doing some targeted education around heart attack care. We're developing a paramedic training process for the response system, and we're making sure that they're well trained to take care of both heart attack and cardiac arrest. There's a lot of protocol development that we're putting together right now with the help of the Chicago Fire Department. Peoria is helping us with this, and University of Arizona. This is an interdisciplinary partnership that has involved emergency medicine, cardiology, and cardiothoracic surgery, by the way. We're also having to think through some policy reforms around insurance. Secondary prevention will be part of this as we discharge patients. How do we promote risk factor reduction at discharge and continue risk modification going forward? So I think it's been very exciting to see some of the things that we've learned in Illinois to go to India. I'm very excited too to see, we're developing technology platforms that I could never have imagined here in the United States, and seeing it go live in India, I think it's very exciting. Some of the ways they think about workforce development in the health system is absolutely unbelievable. There's a cardiothoracic surgeon there that is doing cabbages for like $10,000. And the outcomes are amazing. And he's redesigned the way, like he's looked at, like we really don't need a nurse for this and this. We could use a technician for this instead. It's a very interesting way to look at the health system, and it's exciting to be able to think through this type of project with experts from India. So I'd like to just see if I could play a couple videos to show you. It'll give you a couple ideas of what we're. So one of these is just and again, as we reach out to the community, I think it's going to be important for us to communicate things that they can do in their own community to help with outcome. And how do we use social media? If you have ideas here, I'd welcome those ideas. We don't have a monopoly on best ideas. Certainly we've made our own mistakes along the way, plenty of them. But this is one social media piece that came out. We did not develop this one, but gives you an idea at least of what the traffic looks like in India and what some of the issues are in developing a response to emergencies.
तो आपके हिसाब से अगर 10 क्रिटिकल कंडीशन है उसमें 10 बजे कितनों की जान बच सकती है? 10 की जान बच सकती है पूरे 100%। वाह, कि अगर लोग सिर्फ साइड देना शुरू कर दें तो जो 10 क्रिटिकल कंडीशन केसेस आए इनके पास 10 में से 10 की जान बच सकती है। 100% सक्सेस रेट। ये भी इमरजेंसी सायरन ऑन है। देखिए कैसे लोग बीच में घुस रहे हैं। I mean, हम क्या सोच के सब पर उंगली उठाते हैं कि सरकार मदद नहीं करती हमारी, पुलिस के ऊपर ब्लेम करते हैं। हम खुद क्या हैं? आप खुद देखिए। हमें जब मौका मिलता है किसी की जान बचाने के लिए तो हम साइड भी नहीं ले सकते।
So you can see that in a community where most people don't take an ambulance for their emergency needs, they might think that this is not an important thing when an ambulance is right behind me. But when we've been out there, you see this a lot. The 108 ambulance has got the lights and siren, and it's just basically standing in traffic like everyone else. And so that's a real barrier to providing timely care. One of the reasons why we're using a scooter system, I think 108 is starting to look at that too. But at some point, there's going to be some public policy and new laws that I think would have to be put into place to help with this. And then the other piece is an educational video that we've done in Illinois Heart Rescue. And again, this is about how do we communicate with kids to bring concepts around cardiovascular care and CPR into the home. And so this is Artie the Heart. We actually played this for a couple high schools in India. They're already thinking about how they can put a video together over there. This does have Hindi subcaptions.
Take my dog to the vet.
Yeah, those are good fun sometimes.
I don't know, not too much fun.
You guys are cool.
Let's take my dog to the vet.
Yeah, those are good fun sometimes.
I don't know, not too much fun.
Hey guys, the corn is ready and it looks delicious.
Damn, thanks for throwing such a sweet fight night party.
Ah, you got it.
Hey, check out some beauty back there.
That's weird. Tim never falls asleep when there's still food.
Sleep! You dummies need to wake up! Can't you see this man is in trouble?
Maybe.
Well, check. Look, this guy isn't sleeping. You need to check if he's in cardiac arrest.
Where do we start?
First, check to see if he responds to his name.
Tim.
Tim! No! He's not deaf. His heart is beating. Now check if his breathing is short and fast, like a fish out of one.
Maybe he is in cardiac arrest.
He is! Cool!
That's bad, right?
Yeah, that's bad. But she's done the first right thing by checking for cardiac arrest. High five. Great. Now what? Seriously? Make the call. Right. Who will call? 911.
Wait a second. What happens if the police come by and discover that someone's illegally pirating cable at the big fight tonight? Hypothetically.
Listen, pal. It's not worth letting your brain die. If it's worried, you might get in trouble for something else. Make the call. Put it down. It's time to start CPR.
Oh, I'm not kissing this guy.
You don't gotta put your buttery mouth on him. You only need to do chest compressions. About 100 compressions every minute. Put your hands in the center of his chest, under your shoulders. What do you call that?
I don't want to hurt him.
It's better that he has broken ribs than die. You need to push down about 2 inches.
Do you have a ruler or something I can use?
It should feel like you're trying to press him in hand. The ambulance on the way.
How long do I have to do this for?
Come on, boys. Someone's got to compress until the ambulance arrives.
I got this. How do I know what 100 beats per minute is?
Like this. Now, speaking of beatboxing, did you happen to see a box with a picture of a heart and a lightning bolt on it? Always?
Hey, this box that has AED written on it?
Jeez, why didn't you tell me you had the AED?
Question, what does AED?
Automated External Defibrillator.
Oh, so I just give this beatbox to the paramedics when they arrive, right?
No, doofus. The AED is for the public to use.
I don't know about that. I mean, I'm very bad with technology.
Oh, for crying out loud. Just do what it tells you. You can't screw it up.
The patch adds the bare skin exactly as shown.
He's in here, guys.
Come on! Why aren't they loading him into the ambulance and taking him to the hospital?
These EMTs need to get his heart pumping now.
You said time is precious.
Time is precious. But don't panic if they don't drive away immediately. They have a better chance of saving him if they aren't flying around corners and boxing at 80 miles per hour. Wow, for a group of complete incompetents, you three were pretty heroic.
Cool.
Awesome. We did it! Wait, what do we do? Checked for cardiac arrest, called 911, and you pressed the chest.
And we used that beatbox thing.
That's right. Great work. Group hug.
Hey, so thanks for your attention and welcome any questions if there's time. You could also stay a little late to talk as well. But I think this is a great idea to bring so many people together and from different disciplines. So thank you.
Thanks. Q&A.
That was great. I was just wondering, in this network you've established, whether there's any talk to primary prevention. By the time someone's had a heart attack, there are a lot of prevention opportunities that have already passed, including risk factor control, and are the figures you give on healthcare access are worrisome from that point of view. I'm wondering if you could comment on primary prevention opportunities.
So there's a lot of opportunity for primary prevention. It's not in our budget in this grant. So one of our strategies is going to be we want to look at grant funding opportunities that, as we get data, we can really define what the magnitude of the problem is and approach corporations, others that there's a fair amount of corporate money that is going back into corporate social responsibility grants. And so we want to use that data to look at funding for exactly that, and things that might even prevent their own protect their own employees as part of wellness efforts.
I think to piggyback off that question, it would be in the future it would be good to talk about like air quality, especially in India, and how that increases the cardiovascular.
That's a great question, and I think that from a science standpoint, there's a lot of opportunity to understand the relationship. And again, remember, we are going to be collecting data on cardiac arrest, but we're also going to know what day it happened and what air quality potentially look like. Are those related? Probably. COPD is number 2 in terms of the burden of disease in India at this point. And that's certainly one of the things that when we visited India, that has been a profound, it's compelling. When you go into your hotel lobby and it's smoky, and it's from the outside, there's a big issue with air quality. And so, if you have ideas on how to look at that and measure that as part of this, I think that would be a great idea.
Terry, very nice. You know, in the world of pediatrics, we found that the middle school children are the best educators, actually.
Yeah.
So there's good data for AED use by middle school students. In fact, they follow the rules better than just about any other age group. And in third world countries, particularly in Central and South America, teaching the middle school students what respiratory distress looks like in infants and young children have improved mortality in childhood illness. So it's great that you're doing this in high school students, but seriously, think about moving it to the middle school, because they're often looking for science also to educate, and it's really the group that has, at least for our area, that's been demonstrated to be the most useful, because they have they're willing to follow rules, and they're okay with speaking up if they follow the rules, and they can be trained. So you might think about that, particularly in India. I don't know about here, but.
So that's a great point, and you know, we are, you know, so we actually have a grant application we're putting in for our Champions program that is going to use our high school students to reach back further into middle school and use them as champions of change within middle school. And so you know, that's a strategy that, with keeping that in mind, that it's the middle schoolers that probably could be even more profoundly active. But one thing that we have realized in our Champions program is that when you have people in front of you that look a lot like you in terms of your age, and I could imagine myself being like you in a few years, that's what we want our champions to be for the middle schoolers ultimately. So that is a direction we're looking at. And again, if you have ideas on how to do that, I'd welcome that.
I definitely think what she suggests is great, because health literacy among the school children is definitely will go a long way, because I don't think we have much on that side.
Is there somebody in the back here that has been waiting for a while?
No, thanks for your presentation. It's really interesting. What I was going to ask you is, how much thought have you given to incorporating the help of students who you might come for short-term projects? I was thinking of advanced practice nursing students and preventive health or health promotion in the community as a possible opportunity. The state wouldn't have to be one to kind of build on your needs assessment and develop a short intervention and train the trainers for that sort of thing.
So Rhea, what do you think? Marcia? Yeah, so we have some budget for, visiting fellows, and that would probably cover students, and if there are a budget in the colleges too for students, I think we'd welcome that. There would be some amazing places to rotate through, as it were. So St. John's, Dennis Xavier has got one of a premier training community health workers for prevention, risk stratification, and so that might be a good place for them to rotate and then use what they've learned at some of our help desks at the hospitals. We also we're partnering with a government hospital that actually is the largest, by volume, STEMI hospital in Asia. It's just amazing how many STEMI patients they see, and I doubt if there's not as much secondary prevention probably as there could be for patients that are discharged. It would be an amazing learning opportunity, and we also would like to engage those patients more as to find out what were the barriers to care to get to where they were, so that we can design a better system. So we'd welcome students. So make sure that
The young people can be great advocates on secondhand smoking bans and things like that. You've got 40% smokers there. You've got a lot of exposure to secondhand smoke, and it's a major risk factor for what you're talking about.
Yes, it is.
In addition to all the environmental risk factors that are obvious that you have listed, it's also, from my understanding, a genetically high-risk population. So there's an intrinsic regional genetic variant that predisposes people in South India to early onset ischemic heart disease. in terms of primary prevention, simple things like family history may be an obvious and maybe easy target to sort of identify high-risk populations and study those, or at least educate.
Yeah, so you're bringing up a really good point. So we're actually seeing it in our own Illinois Heart Rescue Project. There are hotspots in South Asian communities that have a higher incidence of cardiac arrest than other places, and there is a genetic difference in fat metabolism in Asian populations, which combined with a new diet is a bad thing. There's also differences in coronary anatomy that can play into this. We are trying to, and if you have ideas on this, that would be welcomed. We're doing a risk stratification process at our hospitals that takes less than 5 minutes. We're piloting this. It takes into account family history, I think BMI, smoking history, obviously, but it creates a very, very nice chart based on World Health Organization graphics that this is your risk. You could modify it if you quit smoking by this. Can we help you with that? We think that's a start.